So primary care, I think, has a great opportunity to really assess patients at the first touch when they enter into the healthcare system. It's very rare that a patient would start their care with a specialist, and primary care is where most people will go outside of some sort of acute care setting. So their ability to discuss with patients the individual risks in that patient, as well as some of the risks of treatments that they may be exposed to, I think is an ideal time to really set patients up for success. Very often we see that over time, patients may develop problems, and looking back, certainly those might have been mitigated, avoided, or prevented. And I think primary care has a wonderful opportunity to really incorporate some of the things we have learned on the specialty side right into their everyday practice at the front line. The way that clinicians distinguish between behaviors is all across the board. Aberrant behaviors, things that make those clinicians really often not want to work with patients who have pain because they see things they don't understand, rarely, though, go through a differential diagnosis process, meaning that if they get a drug test back and it comes back inconsistent for something that they didn't expect to find, and that's, of course, assuming they did a drug test, they often take it as, well, we need to just stop treatment, I went out and try to find the door. Or behaviors like on a Friday afternoon, if they get a call saying, I'm out of medicine, I left it at the hotel, or just, these are things that often healthcare professionals are not really educated on. They don't know why some of these behaviors that they observe are occurring. So how do you make a list? Just like you would make a list if somebody came in with chest pain. Somebody with chest pain, is it a heart attack? Is it a cardiovascular issue? Is it myofascial pain of the chest wall? Is it some other GERD? Is it something other than what it might look like as they're rolling through the door? And when these aberrant behaviors occur, I hope to at least have people who attend a session on this have some idea that there are a list of possibilities that often can at least be considered prior to making a determination as to what they think they're observing. Part of the drug testing experience that I've had is that all drug testing is not always equal, and labs make error, and sometimes we get results sometimes that don't make sense, and it turns out they don't make sense. And they don't make sense because there was policy violations at the lab, or different things can occur. So it's important to listen to your patients, and really that fundamentally is what we should all be doing when patients present, is listen to them, conduct our exam, get the supporting data, and put all of that together to make a differential diagnosis, and really work through that diagnosis when approaching any health condition or aberrant behaviors. So it's an interesting question thinking about how you broach the topic of an aberrant behavior. I think that we shouldn't hide behind these behaviors. I think that patients need to understand what risk means, and they need to understand what we observe. And as a healthcare professional, I often think of myself very much like a healthcare consultant, meaning that the patient, they come with the problem. My job, my opportunity, is to look at the toolkit that I have and say, is there anything in there that can help this patient have less pain, live a better life, and be more functional, and have less risks of the treatments that I might provide? So it's not about me, it's about the patient. So I feel very strongly that we need to communicate what we observe, and if we see things that are problematic, we need to put them out in front of the patient. I often talk to the patients about risk, and I try to use the analogy about cholesterol. And that is, if somebody has a high cholesterol level, we know they're at risk for having a heart attack. Now, will they have a heart attack? That we don't know, but they are at risk. So if somebody comes in and they've got a strong family history of drug and alcohol abuse, they themselves have a history of drug and alcohol abuse, they have psychiatric comorbidities, they need to know that taking an opioid is putting them at much greater risk of developing an aberrant behavior than somebody that doesn't have those things. Now, will they develop aberrant behaviors? Don't know, but they're at risk. So they need to be very cautious taking an opioid, and we need to make sure that we do our job in overseeing their care to really steer them down the path so that they don't suffer some sort of treatment-related harm, and we are kind of asleep at the wheel. So I really think that risk is something that we need to talk openly with patients, not tiptoe around it, but it's for their health and safety that we have that discussion.